All right. Well, we have a really exciting conversation today, and we're going to be discussing one of the biggest questions in aging biology as it stands today. And that is, how do you measure immune function and immune aging in an individual? And how do you use that information to guide decision making? Which I think it's widely recognized in the field that this has been a very big gap, but we're finally getting to the place where we have something we can do about it. And we have some new tools that are allowing us to make those sorts of measurements that we've been lacking. And to discuss this, I don't think we could have a better guest than Dr. Natalia Mitin. She's a leading authority on cellular senescence and aging. Her research spans age-related diseases, including diabetes, cardiovascular disease, cancer, Alzheimer's, and she's really been a prominent voice on early aging and analyzing cellular senescence and immune function in individuals and using that to enhance physical performance, health span, and longevity. Her background includes a PhD in molecular biology and a foundation in chemical engineering. She served on UNC Chapel Hill's faculty before founding Sapere Bio, where she continues to innovate in aging science and longevity medicine. So welcome, Dr. Minton. Very nice to be here with you.
Thank you for having me.
So why don't we start, if you don't mind, in your own words, why don't you set up the problem for us and discuss why the work you're doing is so important and why we should all be paying attention?
I think it's the immune system almost doesn't need an introduction. As we all learned during COVID, immune system is really important. But in general, as we think about aging or just, going through life, because really by aging, I mean, 30s on, like it's not sort of problem that old people have. But immune system is a fundamental system that underlies everything that happens. So it accumulates the stress response from everything you come across from birth essentially. And it also, so it has the memory of these things. And every single thing you do in your life, your sleep, your stress, all of that, all these things, they all affect the immune system. And so when we think about the sort of preventative medicine space, the way it stands right now in the longevity medicine, however we want to define this space. When we think about preventive medicine and our goal of kind of understanding the whole body experience across all sorts of things, so we measure cardiovascular health, we measure metabolic function, we measure cognition, we measure liver, kidney function, gut microbiome, metabolome, you name it, right? We don't measure immune system, and so I mean, the immune system, first of all, it's weaved into everything in your body. But second of all, it's the thing that, decides whether you're going to get pneumonia and end up in AR or not. Like it's a fundamental thing that makes you healthy or not. And so it's a huge gap because the traditional sort of CBC counts when, we look at total number of lymphocytes or red blood cells or platelets or whatever. That's not really it. That sort of shows you if you have, massive infection, but it's not really showing you how your immune system is doing or not. And so it's used for very specific cases in a hospital setting, essentially, where it has value and where it's been developed. And so the ability to measure immune system, we always call it an early signal, but what we mean by that is not even that it's early before you feel it. Like you can't feel your immune system. Like it doesn't, it's not pain. You're not bleeding. Like you can't really feel a decline. So it's early in the sense that it's before the clinical presentation of other things. And yes, eventually it will lead, if you have diabetes, your immune system will be impaired. So there is obviously connection between the immune system and disease, but it's the onset of immune decline well precedes any sort of, traditional sort of chronic diseases as we think about disease of aging. And so, like you said, I think it's a major gap of not being able to measure it and not being able to see the complexity of the immune system in a way that, that acceptable and sort of accessible to people, you know, it kind of across and not just in the hospital setting.
One of the things you brought up, we should maybe dig in a little bit deeper because I think, a lot of us were accustomed to thinking about the immune system in a very straightforward way, right? It fights infection. I think we all know that. And that's important, but you've highlighted that it's doing much, much more than that too, right? And I think we sometimes gloss over some of those other functions and they maybe this makes us forget about the associations with some other diseases. So could you talk about that a little bit? What do people underappreciate about what the immune system is doing in health and disease?
So the two sort of kind of obvious examples that would be relevant to a lot of people. So 70% of your immune cells actually exist in the gut. So when you're thinking about, gut dysbiosis or dysfunction, or I'm eating this kind of food and that kind of food, your immune system responds to all of that. It's exposed to all of that well before it goes anywhere past the gut. So it's sort of everything you eat essentially is stressing your in a good way or bad way, like it's affecting your immune system. So sort of understanding, and then we are a system in balance, so your immune system does find the balance with the microbiomes, and then when you change in diet, you're stressing, or you start dieting, for example, you stress it again. So it's sort of there's a very tight connection between your gut, your lining, epithelial lining, microbiome, and immune system that exists in the gut. And then once that stress signal is created, once that inflammation starts to be created, then yes, it can permeate into tissues and go everywhere. So the sort of the fact that your immune system doesn't just exist like in your arm in the artery floating around, but most of your cells are actually in your gut. Like that's sort of one thing that I think people forget, that there is immune on the like it, if you like fast frequently or too long, you will get sick. Like people anecdotally know these things, but they don't put two and two together, right? It's not. It's stressing immune system at the site of the food intake, essentially. And the second thing I think is the cardiovascular disease, right? So we kind of have the model of you have excess cholesterol, you form a plaque. There is plenty of evidence suggesting that people with normal cholesterol can still have a heart attack because they have inflammatory component to that sort of plaque formation where it goes through the vascular system, through the vessel, and creates inflammation in the space within the vessel. So I mean, again, it's sort of, so where does the inflammation come from? Inflammation comes from the immune system. And so how does inflammation happen in the immune system? When the immune system is out of balance, you have some area of immune system responding with a call activation, and some area cannot stand down, calm it down, then you create inflammation. And so it's again sort of, we use inflammation all the time, and that basically means all the things, right? Like arthritis is inflammation, diabetes, everything is inflammation. But it is everywhere. It is very true. And creating inflammation, will cause problems in tissues because the T cells would go into the tissue. They're, overexcited. They're going to become cytotoxic. They're going to start killing things. That's, people get autoimmune disease. So it's sort of, so you have like if the immune system is not properly regulated, it's not just like when it comes to immune system, I think one thing that people can, it's sort of partly also social media flattens it, but it's not good or bad or strong or weak. It's balanced or unbalanced. Like the weak immune system, that doesn't mean anything. Neither does a strong immune system. Strong immune system can give you severe autoimmune disease. Like that's not a good thing either. So it's sort of this idea that it's a system in balance, and you have to, when you do things, you have to consider how it affects individual domains, and therefore the balance, not just this one thing, is really important. And that's why we measure, because there's only that much you can read, and fundamentally we have very little evidence out there to indicate what different things do. So measuring is, in my opinion, is the only way to actually know.
Well, and getting back to that part, I wonder if, Grant, if you could pretend for us for a moment that you don't know Natalia and you don't know about the test that Sapere has developed, how do you evaluate immune function and immune system aging in a patient, with the tests that we have available today, and what are the big gaps that you have in the clinic?
I think that a lot of the slides that Natalia's provided with this really challenges we're doing in regard to assessing. We're going to take a look at inflammation. We're going to take a look at altered gut permeability, which to a significant extent probably relates to a lot of autoimmune disease. And it is a challenge as to what you do about that. There's lots of testing in that area, but it's not really that direct, apart from saying, look, you've got this inflammation and you're getting some lipopolysaccharide antibodies into your bloodstream. You've got a positive occludin and zonulin, those types of things. As far as saying, do you have a balanced immune system or not? I don't have anything that I've been using that really gives us a good sense of that. I mean, we do absolutely appreciate, and certainly during the time that COVID first hit, it was a very sobering time because you'd see people that weren't necessarily that different than yourself who were having major functional immune responses and getting major inflammation. And you look and you go, well, what's going on with them? And if I catch this, is this going to be me also? That I'm going to be on a ventilator, I'm going to be dying? Or is it something where, my immune system is better? And looking at, the high sensitivity CRP, looking at complete blood count, looking at, ferritin and GGT for inflammation, I don't think really answers the question. And that's where I think that this testing is interesting, that it has been developed to understand, is there a reasonable balance in the heterogeneity that is evident of where you can have somebody who's, 80 and has a very balanced immune system, you can have somebody who's 35 who doesn't. And then the secondary question as a clinician is, when you have somebody who's unbalanced, what do you do about that? And I appreciate we can do some things and retest. And I suspect that Natalia has some insight into what are the things that end up changing a imbalanced immune system. But then there's all these domains that she has as far as, defense, stemness, balance, senescence, inflammation, and kind of an overall score of, how do you then deal with that data if you end up getting somebody to take this test and then recheck it. So I think there's a real challenge as far as taking a look at, do we have a functional immune system or not? I don't think that I have great tests for that until now.
It's an interesting, so you brought up a really interesting point that we hear again and again. And we can talk about what the test does, but this is a perfect way to say what test does. So we hear it from physicians all the time. We got, this person had got dysbiosis. This person has high viral IgG, or some other lab test showed something. Then the question they're asking, does it matter, right? Because a lot of times people don't have longitudinal data. They don't know. Maybe you've been like that your whole life. And so it's does it affect immune system, or it's just a titer and it's just there and it's not really doing anything? That's where I think people find the most value. And that's why we as a company recommend that everybody has a longevity partner, physician partner, whatever that can help you think through those things. Because let's say inflammation comes back high. The test will not tell you where it's coming from. It can flag it, but it's a tissue. I don't know. And so be able to track these things down is essential, because otherwise you're not going to get the value out of it. I mean, it will be very scary, but you're not going to get the value out of it because you would not be able to do something about it because you don't know why. So to be able to sort of to follow the path and figure out which domain is impaired and why is critical. And so if people can do it themselves, kudos. But generally, it's a very tall order.
Well, then this brings up one more piece that I think maybe we should set up perhaps a little bit more for people before we dive into the test. We've talked about this idea that not everyone's immune health is the same, right? And I think you've both suggested that when you're evaluating someone, you have a patient in your office, or let's say you're trying to evaluate yourself, it's not very easy to tell who has optimal immune function or average or suboptimal, even with the clinical tests we have, right? It's just, it's a puzzle. And I think, what you see in the research domain is that with these, groundbreaking new research tests, we can tell what someone's immune function is, and then we can follow those people and we can see what happens to them over time. And I think the public is unaware just how dramatic the differences are between someone with optimal immune function versus someone with suboptimal immune function. I mean, it's an absolutely massive difference in health trajectory, and yet it's something that the modern medical system is paying no attention to. We don't evaluate this in anyone. We don't track it over time. We don't use it to decide what someone's at risk for, even though it's an excellent predictor of risk. So I'm wondering if you can, maybe just take us through that a little bit more, just truly, whether it's in the context of immune health grades, or we could do it in terms of thymic function, right? There were 2 really big thymus papers that just came out with some pretty startling predictions. But maybe take us through what this means for people. What if I come in and we evaluate me and we find that my immune function is terrible? What does that mean for me?
So remember, there is no such thing as terrible. There's always room for improvement, or not, or maybe it's perfect. So the way I would think about that. So first of all, again, what the test doesn't do. It's not a morbidity score. If you come in and your CRP is 300, you probably should go to the hospital. This is a test of resilience. So yes, if you have, MS, or like if you have some severe disease, the markers will, but you already know you have a disease. You don't need this test. I mean, the test will show you that your immune system is also bad, but it's not really adding to your diagnosis or treatment. Like, you're going to be treated for the disease you have that is causing all this immune dysfunction, right? So it's not, immune system will not be a primary target, and it shouldn't be a primary target unless it's an immune disease. So there's sort of the like when your results come back and your T cell exhaustion, your defense is 3 out of 5 instead of 5 out of 5, you shouldn't go to the hospital. You shouldn't start ingesting things you think will, like, it's a flag. So
Yeah.
when we think about the the resilience or senescence for that matter, it's like, so think about resilience as is a true resilience, right? So you have your full resilience, your immune system is perfect, you got some from your mom, then you build your own, you're perfect, right? Then you go through life, and some people have more exposure to viruses and live in polluted environment and this and that, and just sort of physiological stress, you overexercise, whatever. So you kind of have these insults. You get sick, like your immune system is declining, then you start to get sick all the time. You have this accumulated stress. And so the first time you get sick, you bounce back as a kid, right? You got sick, you barely noticed. It might be running for 2 minutes. Adults who got the same strain are out for a week. Like, so you have a lot of resilience, right? But as you go through life and as you continue sort of going through these stressors, you wear out your resilience. So then every time you get exposure, you get sick. It's not that do you have it, do you not have it? It's a very much a gradient of resilience, right? And so what we measure is resilience. So for example, one of the metrics is immune longevity score that is built as an immune resilience predictor. When it comes back at 0, it doesn't mean you don't have immune system by no stretch of imagination. It just means that you lost resilience. So it's not, again, like, you don't need to go live in a bubble and avoid society, and like, it's not a dramatic, the marker means you have disease because it's outside of optimal range. Like, it's not the traditional clinical thinking of what the outside range means. And what the range is up to 50 and I'm 100. Oh my God. Yes, you're on a range, but and we frequently see people who have immune longevity score that is 0 or below the detection. About 50% people in sort of longevity space with test have undetectable resilience. Like, it's a real phenotype, but they're still walking and talking and living their life. So it's not like a huge, oh my God, this is bad. So first of all, kind of setting your own expectations that it's always a room for improvement. It's not something that is gonna be like dramatically different, right? The second point is, because we have this resilience, so immune system, because it's your protection for life, right? You build memory T cells that literally last a lifetime, right? So it's not meant to be dynamic. The adaptive immune system, sure, but the innate immune system, adaptive, is meant to be stable. It's meant to respond only when needed. And then remember, it's not reacting to everything. So building sort of that resilience and that ability to kind of be stable is an inherent property of T cells in an adaptive immune system. But that means it's also kind of hard to change, because not everything you do will actually move it quickly. Like, it will move it, but it might take 3 to 6 months. Like, the fastest we've ever seen was 4 weeks. So it's not like you got on statin and 2 weeks later your cholesterol dropped. Like, it's not an immediate response, right? Which again is a good thing, because if you can move things that fast, that means they can also move fast in a bad direction. So it is sort of, it's a protective mechanism, but it also sort of, again, kind of setting people's expectation for how long it takes to get a better result. And then also, we can come back to that. I'm sure we'll come back to it multiple times, but the larger the stack, the more there might be a problem. And especially if the stack is also all these cutting edge treatments that are coming out that may or may not have been tested in human beings. Because nobody tests the impact on the immune system, because nobody can test that. And so therefore we have no idea. I mean, thymic regeneration is sort of, at least it's in the immune system, but all the other stuff, like, it's not just there's no safety profile. Like, we have no idea what it does to the immune system. Like, we can speculate, read papers and predict, but as a scientist, I know that there's a 50% chance I'm right or wrong. Like, that's, you can't really guess. And so I think it's sort of the, like, going into it with that your result is a flag for early, like, for understanding where you are, and then deciding, like, as we were talking earlier, it also depends on your goals, right? If you, like, sometimes when people overexercise, they really damage their immune system. But if this is really important to you, you want to run this marathon in memory of the loved one, and you will do anything to do it, do that. Like, if that thing you're doing is really important to you. Yes, it might damage your immune system that you will have to recover later, but if it's really important, do that. But again, understanding that, this is a trade-off, and knowing that that could be a potential trade-off. I think there's also where people kind of forget that it's not all or nothing. Like, sort of, you choose some things at the expense of others, and we all make trade-offs.
I have a bit of a question here, and it's interesting looking through the slides that you sent through, which I think are really excellent. Kind of the concept of putting something that's too challenging in front of your body and doing harm to your immune system, with your classic one being overtraining. I've got my personal situation, which I find interesting. I'm not sure if anybody else does, but I'll see if they find it interesting. I oftentimes get exposed to COVID and influenza 20 or 30 times per week, deliberately with no mask on. I look in people's throats, they cough on me. So I'm getting exposed to a massive amount. You could kind of go, hey, is that going to overwork your system and end up causing harm? Or is that going to be beneficial? So how do you determine the healthy middle ground? And what I would say is that when I get exposed all those times, I basically, if I get the snivels, it's for like 6 hours. I don't get sick from it. So I'm getting all this massive exposure, and yet my immune system probably seems to be loving it rather than hating it. What is the differentiator between, too much, and how do you measure that versus, too little, so that, if I don't get exposed to COVID in a year and I get exposed, I'm probably actually going to get sick from it. We're getting exposed to it 20 times a week. No big deal.
Well, but I mean, that's a perfect example, right? So let's say we test you. If your T cell exhaustion shows strain, that means that those viral exposures are taking a toll on your immune system, on your T cell exhaustion specifically, right? If they don't, that means that yes, you're exposed and you make some antibodies, but your adaptive immune system never engages, because your innate system took care of it. Like, you don't need to make more memory cells, because you already have some. So your immune system, because it's also like, it's a novel exposure that kills you as you get older, right? Like, if you get exposed to the same thing, like, your immune system is excellent at handling that. That's what memory cells are for, right? So as long as, we don't get COVID strain, 6.0, then your immune system will see it as new thing. But if it's the same thing, it doesn't matter if it's 20 times or 10 times. I mean, I'm sure exposure matters. I'm sure people tell me that. But, I mean, it's that, right? So it's being exposed to the same thing. If your immune system can handle it, it can handle it. It's the accumulation of different things, especially, when you travel and you're exposed to things your immune system never seen before, like that kind of stuff. Like, that's where adults, it's adults getting childhood diseases, right? Like, it's your immune system doesn't know what to do with these things, because it's never seen it.
And I have one add-on question with this, and with the thought of whether you're able to regenerate your thymus. The discussion's been on with the Trimax trial, and going, hey, on MRI, your thymus, seems to come back with active tissues. T cells seem to be looking better. What are your thoughts around that, as to whether there's actually a mechanism to set your immune system back 20 or 30 years, so that you're responding more like somebody who's significantly younger, rather than the typical dysfunction of somebody who's, 55 or 70?
Yeah, and I mean, that's kind of the promise of the trial. So John asked earlier about, sort of mentioned the thymic papers that came out, where people did sort of AI-driven MRI, essentially, of the thymus, and got AI to define the thymus better than a radiologist, and then showed that there's just massive benefits across disease, like death and diseases, of cardiovascular being one, but really basically everything, because immune system matters. So it's sort of, I mean, the when we talk about immune resilience, the study from San Antonio showed that there's about 15-year health span difference between people who have high resilience versus who have low resilience. So it's however way you slice it, whether it's in years or risk of disease, or having good immune system benefits you. That's just, there's no question about it. So when it comes to TREM trial, so we have people who started the trial, but we don't have the follow-up yet. So I don't know the answer in our own hands. What I do know is the growth hormone obviously is nothing new, certainly in this space. And we have seen massive suppression of T cell proliferation by people taking growth hormone. So not in the setting of a TREM with, DHA, and for sort of to kind of counteract the glucose effects. I don't know why that would matter for T cell proliferation, but technically it was not the same protocol. And so people who are on growth hormone, when they, went off it, like, good news, proliferation recovered. There was massive recovery from 20 percentile to 90 percentile, like just massive recovery. But like testosterone does that too, that suppresses T cell proliferation. There's some things where not great for your immune system. So yes, you use it to grow the thymus, but it is an anti T cell proliferative effect. So you restored the compartment and technically got the naive cells back, but now they have to proliferate. Will they, it's like donor transplant. Are they suppressed now and then they will recover, or they're suppressed forever? Like, we don't know. So that's, and I can speculate either way. Like, I can make a case either way.
So the important thing with that would be if you were to say, I'm going on growth hormone for the next 5 years, you would never get the proliferation, you just get the downside. So it is something where you're saying that there should be a well-defined period of time where you do this and then you stop it, rather than saying, hey, I'm going.
There should be a well-defined period of time, and also in the context of your own immune system. So what I mean by that, sort of, let's just dive in. So when your adaptive immune system responds to something, right, you have T cells that are proliferating. Like, we can call that activation, but basically T cells proliferate. Then when T cells proliferate, they take care of infection, and then they kind of, go down. So they form memory cells. So this ability to go from activation into remembering the infection and standing down is really important. And that's and then immune system comes down, right? So while it's engaged, while it's activated and, it's taking care of infection, it's secreting a lot of inflammatory factors. And there is, it's like, think of wound healing. There's all this stuff going on. Immune system is being crazy in that area because it's trying to get rid of the cells and, form the, bring the fibroblasts to heal the wounds. So there's a lot of immune activity going on. So if you think of it as a river, and now you blocked the ability to make memory cells, so you're already activating, but you can't actually form memory cells, all that inflammation is yours to keep. It's not going anywhere because the immune system cannot stand down. And so from our test, if your T cells are exhausted, and I'll explain in a second what that means. If your T cells are exhausted, they cannot form memory, or at least they're ineffective in forming memory cells, and they can also not respond. So when you have T cell activation but exhausted cells, you can't form memory cells, you create inflammation. So if you're messing with T cell proliferation in the context of already high exhaustion, you're throwing your immune system out of balance. So two people going in a TRIM trial, one has high T cell exhaustion, one has low T cell exhaustion, or at least optimal T cell exhaustion. There's too low is also bad. May have different response. So it's again, like, we frequently get on calls with physicians where they're trying to figure out if somebody's a candidate for something, and it's always that, well, they have autoimmune disease, so the immune system was already overreacting, but they want to do this. Like, you have to figure out what else is going on, because you're trying to rebalance your immune system, not just push it, right? And so understanding that, the change in this domain for one person and the same change in another person could mean completely different. And so that's where the complexity comes in, because we don't know. Like, I would be the first to admit, I actually have no idea who would be a good candidate or not, just because we don't have data, and it was not published that way, so we can't draw from published studies. But I know scientifically and sort of with my gut that I know that to be true, because that's just true in life, that there is not one size fit all. So that's there's that.
Maybe, I think this is a great path to go down, but maybe before we get much further, let's define a few things for people who might not be familiar with TRIM and kind of the rationale there. So we've been talking about T cells a lot, right? And we've been talking about adaptive immunity. And Natalia, I'm not an immunologist, so correct me if I'm oversimplifying here, but T cells are an important cell type in the adaptive immune system, that they recognize stuff that shouldn't be there, right? They recognize small portions of proteins that aren't part of our self, right? So they could be from virus or from cellular damage, or it's something that shouldn't be there, and then they help coordinate a response to get rid of it, right? Is that fair?
Innate immune system recognizes the threat, whether it's viral and then engages B cells, and that engages T cells. So it's a whole symphony of things. But yes, T cells are the ultimate responder. So if your infection or, whatever the challenge is severe enough, T cells, and that's what Grant was asking, if your challenge is severe enough, your immune system will respond. If your adaptive immune system will respond.
Perfect.
Challenge is just kind of like, oh, we've seen this before, not a big deal. We don't need to worry about it. Macrophages got it. The adaptive immune system never triggers. So it's sort of, it also, it sort of decides when it responds, when it's severe enough that it needs to be memorized.
So T cells are these master controllers of the response to these perceived threats, right? And as we age, they're also a cell population that changes a lot, right? Because a T cell is not a T cell. We have recently born T cells that have spent some time in the thymus learning what's a threat and what isn't, and they kind of circulate throughout the body after they mature, and they look for new threats. And if they find a new threat, they can expand to form these memory T cells that you've mentioned, which later can respond more quickly, right? And so the premise of all this thymic regeneration that we've been talking about is that as these cells, these naive or newly born T cells decline with age, we can encourage the thymus to regenerate and grow some more of those. And it's a really appealing proposition, because if that was true, it really could be a way to keep the immune system young throughout life. And so I think it's really gotten the attention of the longevity community. So that's what the TRIM trial is. It's testing this. TRIM-X is the follow-on study that's testing it in a larger population, a more diverse population. And, when we see these results reported, we see averages, right? We see that on average, people's thymuses grow, and they see some suggestions of a younger looking immune system. But Natalia, you're highlighting an important thing here, and that's that, we don't see what's happening on an individual trajectory. We don't know who responds favorably or who doesn't respond at all, or who maybe experiences some negative things. If those T cells are generated but can't proliferate, that's a real problem for ongoing immune function.
I think the important thing to kind of just go to highlight. So thymus is the organ that declines or disappears. The T cells come from thymus. So we cannot make T cells outside of thymus. Like other white blood cells can be made in bone marrow, T cells strictly come from thymus. So if once your thymus becomes a fat tissue, essentially, then you no longer can make T cells. So all the T cells that are made that you keep for life are made, in your 20s and before that, right? So that's your T cell bank. And that's why it's important to make sure you're not, drawing out too much, because that's your T cell bank for the rest of your life. And so so then your T cells are made, and now, so they're new. They have not seen anything. They're called naive cells, right? So that's just sort of, they're naive because they've never been exposed to anything. And as you account things, they can become sort of memory cells or effector cells, or they become other cell types, right? So this idea that you have naive cells that are needed, like, yes, you need memory cells because that's what remembers infection, so you don't keep reacting to the same thing. But naive cells is what keeps you healthy, right? Because it's the ability to respond to new things. And so the thymic regeneration, the promise is that if you get the epithelial tissue back, you can, sort of the fat pad is still there. But if you get the epithelial tissue back and the thymic progenitors, you can form more naive cells. Because these naive cells, they don't just decrease in amount like with age. They don't just decrease in amount as you get exposed to things, but they also become compromised. Like they have chromatin problems, like they become kind of transcriptionally slowed. So even though you have them, like by count, they don't really respond really well. And so you have less and they're less healthy. So that promise is, if you make brand new baby naive T cells, those would be perfect because they didn't hang around for 30 years and weren't exposed to all these things. So that's really the premise, is not just to make more naive cells, but to make them brand new so they don't have all this other problem your other naive cells might have. And so making them perfect is really important, because you already have the imperfect cells. You don't need more imperfect cells. And so what makes a perfect cell? That's the challenge. Right? Like, in which situation do you get the perfect cell? In which situation you get just your own old, non-proliferating cell, and you really nowhere else.
What strategies have you seen actually work at getting some degree of thymic regeneration with these naive cells?
So don't have any sort of experience outside of what's published in the TRIM trial, so can't really speak to that. What's published, on the very few people that sort of participated, I don't really see, I'm not a radiologist, but sort of for what's shown, I don't really see a significant change in the thymus where I'd be like, oh my God, the thymus is regrown. So I don't know, sort of like from the data I've seen, I don't know, just purely published data, I don't know, like, let me put it this way. When I think about treatments, and that's every clinical conversation we have, when I think about treatments, the question is not which treatment can move which domain. It's what are the odds of that treatment moving that domain? Because we have plenty of things that can move this thing or that thing. Is some are better at it and some are worse. And so if you want to do one thing, you don't want to risking some, subpar thing that, yeah, sure, it can maybe do it, but this would be much better. So on that scale of is it worth it, basically, whether it's financial or health, right? On that scale, is it worth it? I don't know where to grade it yet because I'm not convinced that the data is there for me to be able to place it in so I see people trying it and, we'll measure, but I don't really have a good sense for this is definitely the thing that goes on the list of, the top 3 things that we can talk to physicians about. Like I think that's the best way to answer that. I just don't, scientifically, I don't really see anything published that convinces me, and we don't have any experience.
Well, that of course begs the question of what the top 3 things are. I mean, one of us was going to ask it, right?
So before we dig in, so that's why, because we don't measure thymus, like we see the sort of the stemness, our marker of stemness go up, but we don't know, like, is it T cell proliferation that change or actual thymus? Like, we have no idea because we're not doing scans. So I can't really speak to that. But so before we go into, what we think works, what doesn't work, let's discuss a couple of things. So first of all, what does the test do? So back in the day, many moons ago, we figured out a way to measure cellular senescence in human beings. And as simple as that sounds, it's definitely not. And so it's technically challenging. The levels are really low. You have to preserve the sample. Otherwise, it's hugely variable. So it took years to kind of perfect that. And we were cellular senescence people for, forever, right? So I had kind of like so we were testing, we were doing testing, senescence testing with this idea that John, you mentioned earlier, with this idea that, and actually Grant also mentioned it too, that, you're a surgeon and you have 2 50-year-olds and they're not the same, but there's no way for you to tell which one is which. So you can't put it in your score that uses age to decide on the risk to do something about it, right? So you can tell just by looking at them, something is not the same, like they're not the same, they don't have the same, presentation. But so the idea was to use the procedures that I used for aging diseases, such as cardiac surgery, chemotherapy, to understand the risk stratification. Like, should the patient be, I hate the word molecular age, but let's just use it as a placement. Could we use molecular age instead of chronological age to help physicians gather this, like, this person is not like the other? So can we use that to substitute the chronological age so we can guide, like, better patient selection for procedures, essentially? Because frequently, and at least in my network, I hear from people who are like, oh, my parent was denied surgery because, she's 85, but she still lives by herself and all that. But surgeon said, nope, she's 85, not risking it. Like, it's that, right? So sort of the age is still very much a driver of every clinical decision in sort of in the major medical space. But we all know it's just a number, right? This is what we did. And so we had some data. It would have been FDA regulated. So things were moving, real clinical trials, things were moving really slow because that's kind of how FDA regulation goes and clinical trials. And so then, like, I kind of had in my gut, I had the feeling that there's more to it than more to the story than just senescence, because sometimes the picture didn't make sense, that people will have really low senescence, but like you could tell they have diabetes, like you could tell their immune health can't be that good. And so that's where we started, we got the idea of like, we should measure other pieces of immune system because it can't be all senescence. Like, it just doesn't make sense. And so we started measuring, and I can address in a second how we decided what to measure. We started measuring these things and then and putting it together with senescence. And so we look at it, senescence and other immune stuff, if you wish, right? And so right around COVID, there were a number of papers that came out from different labs, not us, different labs, showing that immune surveillance of senescent cells is really important. So T cells, specifically CD8 cells, can see senescent cells and clear senescent cells. And therefore, just senescence doesn't doesn't really tell you what else is going on because you accumulate senescent cells and the immune system clears it. So you have to understand both parts of the equation. If you only see one, you only see one, right? And so that's where the clarity came. Like, oh, well, that's why sometimes we see people with, senescence that doesn't make sense because. And so when we did that study, we looked at 250 people across the population. So from 21 to, whatever, like 80. I think we did like about 10, 15 people the first couple decades, and we did sort of more people in the middle, so we kind of spread it across intentionally as a registry. And we looked at the immune system, the rest of the immune system, and cellular senescence. And what we found is that people where cellular senescence was a sole problem were like 10% of the population. Cellular senescence was never a major problem in really anyone. It was either immune deregulation first, or once you have enough immune deregulation, cellular senescence will increase, but then you kind of go into this phenotype where both are bad. So it's never really, oh my God, these people have a ton of cellular senescence, but otherwise they're perfectly healthy. We've almost never seen. And so the only few cases where we see that, if somebody has a really persistent senescent cell accumulation, and usually it's psychological stress. So you're driving your senescence. I mean, chemotherapy would do that too, but sort of out kind of in the longevity space. The sort of this the stressing of the pathway that causes upregulation senescence, and usually it's in the younger sort of late 30s, early 40s, where immune system is still perfectly fine, but they just can't keep up. And so that's why we measure immune system kind of as a system, right? Because neither one component. And then when we start looking at these things deeper, then we can start to ask which domain has a dysfunction. And then, with a physician, why do you think that is? And then that would lead to what you can do about it, clinically or therapeutically, right? So it's sort of depending on the cause, right? So that's kind of high level. On the second is what we measure. So we measure T cell biology. So as I mentioned, T cells is what we measure. The reason we measure T cells is because everything you think about what your immune system does, it protects you from viruses, it protects you from inflammation, it correlates mobility. That's all T cells. So T cells is the compartment in the immune system that gives you the longevity of your immune system. So therefore you measure T cells. The second reason we measure in T cells is because if you don't pull T cells out, you're going to get a lot of noise. So when people measure in blood, you're going to get a lot of noise from all sorts of other stuff. So there was a really elegant paper that came out not even a month ago, I think, maybe a month ago, from Dmitry Bulavin's lab in France, showed that transient activation of P16 in macrophages, or in monocytes, and become macrophages, was essential for protecting tissue from acute infection, such as, for example, sepsis, COVID. So the ability to increase senescence, and then it went down like within weeks, right? So the ability to increase senescence in response in macrophages was critical. So if you measure somebody's sample and they have a ton of senescence in macrophages, that's a good thing. That's not a bad thing. So if you don't pull the T cell, and sort of that's protective function doesn't exist in T cells. So if you don't pull the T cells out, you're not really getting the answer. And so I think it's a really important lesson for everyone in the longevity community. Like, do you know, it's not just what you measure. Do you know where you're measuring? And is it measured well? And is a sample state? Like, there are all these questions we don't want to ask, but they all matter because it's a difference between a real answer and not real answer that you're going to do something. And so, it is a pretty critical distinction.
Oh, I just very briefly, one kind of practical point, and then I'll turn it over to you for the rest, John. It sounds to me as though you've got a test that could significantly prognosticate or risk stratify people. The question is, are there action points that are very clear that can be made that actually fix the issue, or are you simply going like this person, their immune system is packing it up and they're probably at high risk of having premature death, and but is there actually an action point as a clinician where you go like, okay, I've got this test result back, now I do X, Y, and Z, and it ends up fixing it, or are you just looking at it and going like, oh gosh, this person's actually in trouble, and I'm sorry that you're in trouble.
So to answer Grant's question, it's definitely it's definitely the, you can do something about it, because the reason we didn't want to get into longevity space is because we didn't think that the markers can be moved. because we've never, in a traditional setting, we've never seen it go down, like ever. Senescence was like, you can go up with therapy, but it will never go down. So we did not want to have a test on the market, if you wish, where, to your case of like, oh, sorry, go update your will, good luck. Like that, we did not want to do that. And so until we did the registry in longevity medicine clinics to see, because we were like, we're not launching this. Yeah, sure, we can test and see what happens, but we're not launching this unless we can do something about it. Not like, in the future, but like now. If what you do cannot move it now, then there's no point, because you're gonna just show that it doesn't work. And so, first to admit, to my huge surprise, where, oh my God, that things exist right now that sort of, that we all know about, their own social media and whatnot. And, some of them are published, that can actually move these things in a good way too. Like that to me was kind of striking, because like even lifestyle, and I hate to say even lifestyle, but I don't know about everybody else, but I think of it like there's lifestyle and then there is drugs, right? So you tend to think that lifestyle is kind of marginal, but it has a massive impact on the immune system. And it doesn't have to be, you don't have to be, reading for 20 years to see the difference. Like it's a huge difference, especially if you're going from good to bad. Like it's just like with everything, it's a very dramatic difference that you can make by adjusting things that are free. Sleep better. Like that costs you nothing. Well, it costs you time, but it's sort of, so once we saw that you can actually move these things, that's where I was like, okay, we can do something with it, because otherwise there's absolutely no point. And that's what I mean. If you're seriously sick, like we have clients that have, MS, and they have, cancer for the third time, and or they have like this, long COVID as one example. It's this, really serious diseases, and sort of they're very ill. They got tested because it's part of kind of their package in the membership, not because the physician thinks they can do something about it. They're treating the actual disease. Like that's the first priority, right? Like you have cancer, immune system takes a second place. So it's not really like, it is prevention and catching early is really the goal. It's not going to tell you exactly what to do to cure the serious disease you have. You will have to take drugs for that and get that under control first, and then see where your immune system is, basically. Does that make sense?
We'll circle back. I want to get back to those big three interventions, because I'm sure everyone's going to want to hear that part. But I want to go back to something you said about senescent cells. I mean, you're saying that your observation was that they only go up, they never go down, right? And in the longevity space, we are hearing so much about senolytics in animal models, and the human data is much more sparse, but there's at least reason to believe that some of these interventions have an effect on some human senescent cell populations. But it sounds like that's not what you're seeing, right? You're seeing something very different. And my question is that something that's specific to senescent T cells? Do you think you have a resistant population of cells that doesn't respond, or do you think that it suggests that maybe these interventions aren't as useful in humans as we might have hoped?
So I think that's a perfect place to talk about published literature in mice and us as a human beings who are not mice. A lot of studies are done in transgenic mice, right? They're cheap. They're well characterized, genotyped every which way. You can make your vectors and make your transgenic mouse. Like people do it all day long. You can buy those things from companies and make a mouse in a few months now. It used to be years, right? So that research is incredibly important. Having a mouse model of a disease is incredibly important, because that's the first place you start asking any questions, right? So it is an incredibly important tool. What people need to understand that they are lab mice. They're not even normal mice. They're lab mice. They're modified in a specific way to breed, to grow, like all of that, right? So they're not sort of normal mice. Then there is also, in aging research, we also use what we call progeroid mice, where you sort of, you accelerate DNA damage. And so they age faster, so you don't have to wait for 3 years to finish your experiments. You can do it in 6 months. Like that's sort of, again, mice are expensive, and housing mice is expensive. So again, perfect research tool, but progeroid people are not typical longevity population, right? So that's when anything is tested in a mouse, even if it's multiple labs, there's also multiple strains. So we're not going to go there, but like sometimes it doesn't reproduce in a different strain. And also sometimes mice are fed, sometimes it's what's called oral gavage. So delivery could also be like sometimes it's injection in a tail vein, like delivery could also be different, right? That people taking something that goes through stomach. So then there is ITP, intervention testing program, right? These are wild mice. So these are sort of immune competent mice. They're, actual mice. And so when you think about, and then, then there's canine models and, primates, and and then it's us, right? So there's various levels of evidence one would build to make sure it works. So senolytics, when we have conversations about senolytics, I use that word a little bit differently than I'm guessing everyone else. So when I say senolytic, I mean it's a thing that can decrease senescent cells. So I don't mean Fisetin, I don't mean DNQ, I don't mean a specific treatment. I mean it's senolytic in the mechanism, not in the description of the model, right? So there are a lot of things that can be senolytic, like sleep or changing your nutrition or, controlling your stress. Like that's a senolytic. So senolytic to me is a mechanism. Can something be senolytic? Can it do what it says, decrease? But it can be anything. Like it doesn't have to be supplement. So when it comes to supplements, the Fisetin is the sort of the most commonly tested one and sort of commonly used because doesn't have the chemo agent in it. The data in mice shows so some things are senolytic. They can decrease the actual senescent cells, so the senescent cell counts drop. And some things are referred to as senomorphic, meaning they cannot touch so senescent cell count remains, but then the inflammatory signals that senescent cells secrete, that's decreased. And so the difference between senolytic and senomorphic is the senolytic agent will remove the source of inflammation, or at least the senescence specific inflammation. And a senomorphic agent will just remove the inflammation. So you will just continue making more. So it's less effective just because it's sort of, you're not really doing anything else. I mean, you're still depressing immune system because it's less inflammatory environment, but you're not really addressing the main cause, right? So when it comes to Fisetin, the mouse studies, the initial mouse studies showed that it's a senolytic. In various tissues, the cell counts drop. I always refer people to Laura Niederhofer's lab for any question of, is it tissue specific with this drug? Her lab always does amazing job at just banking these things and having these super detailed papers around, every cell tissue was looked at, measured in the same way. Here's the methods. Like it's always super detailed, and that's my go-to if I want to look at mouse data, just sort of as a personal recommendation. And so they've showed, so I believe the data. So they've showed that Fisetin decreases cellular senescence, including P16 marker, sort of canonical senescence marker in a bunch of tissues and measured. So no question there. In the ITP study, so then because there was so much mouse data suggesting that Fisetin decreases senescence and therefore has a potential, if we believe that senescence drives longevity, if senolytic will typically extend lifespan, or you would expect, or at least Healthspan. So it was elevated to the testing on the international testing program. So that paper came out in 2024 in Neuroscience. What they showed is there was no benefits. So they did the continuous continuous dosing, and then they did mouse dose 600 ppm. They started 20 months, so they did continuous dosing, and then 3 days every 2 weeks for 2 to 4 months. Basically, it's all mice diet. So neither continuous nor on off, like the way kind of I understand people take. Neither one showed any in males or females, so it failed. More importantly, when they looked at P16 in liver, kidney, and brain, so they looked at old mice, so the mice were 20 months old. So they looked at old mice. The P16 was up in liver, kidney, and brain. So they looked at mice treated with Fisetin on either protocol. There was absolutely no difference in P16. So it was not senolytic, at least in liver, kidney, and brain. Could have been senolytic in right aorta? We don't know, right? But it wasn't extending lifespan. It wasn't really changing anything in 2 different protocols. So, I mean, again, like, what does that mean, right? So it's sort of, was the dose not enough? I mean, it's the same dose that was used in previous mouse studies. So at least it suggests that mouse models matter, if you wish. Like, maybe the different dose would have worked. Maybe if you waited longer, like, maybe they were too old to see, and let's see if you would have started younger. Like it's always, right? Like when you do research, it opens more questions than, you have a money for essentially. So, we don't know. And so, John, to your question, when I think about the senolytic evidence, right, I don't see distinction between T cells and tissues. Like the immune system will find these cells and clear them out. There's no difference between liver and brain and kidney, like in that sense, right? So the tissue is tissue, immune system is immune system. So I don't really see the difference. Like you can have different levels of P16 in one tissue versus the other, but like if it's senolytic, it should be senolytic everywhere. You might not get the same percent clearance if you wish, but like it should still be senolytic. So therefore I don't see the difference in the tissue. And then it comes to two questions. One is, does Fisetin actually work as a senolytic in humans versus mice? And is the supplement you are getting actually has Fisetin in? Like you think what you're getting actually with you, like, right? So both could be true or not. And so we had the clinical trial that just closed. So sort of, they're still reading out the data, looking at Fisetin. And so they did dosing for 2 days, every 14 days, 8 cycles. So that's sort of kind of typically what people do. And we don't, like, there is no senolytic effect. So if you look at cellular senescence, there is no difference in cellular senescence. There is difference in T cell exhaustion, which still good for the immune system because it makes the immune system recover a little bit. But like as I was mentioning earlier, the efficacy of treatment, like the effect is so mild, you can get a better things, like better if a response with other things. So on my list, it's certainly not a senolytic, at least in our hands, right? In our patient population, if you wish, right? Because I don't know, maybe it will work in some other people. Well, it's that, right? So it's sort of, maybe it will work in some other people. I have no idea, right? But it's like given the right circumstance, but it's certainly not in the, and then the one thing, like there are a couple things I want to say about senescence that I think I would love for people to remember and kind of carry with them is when you buy something that is labeled as senolytic, you don't know what's there. And just because I'm saying Fisetin doesn't work as a senolytic, it doesn't mean it can't hurt you. And we've seen multiple instances where people's senescence went up on senolytic because there are certain compounds added to make it more bioavailable. It's natural, so they're adding it at the 4x concentration of Fisetin, and then people think they're taking senolytic and their senescence goes up. So it's just because the label says so, that doesn't really mean anything, and nobody really tests. So that's one thing. And the second thing is, so when we, and we'll have it in the show notes, but as we alluded earlier, the levels are super heterogeneous. So what I mean by that is if you look at cellular senescence across people, across population from 20 to 100, like we have some people who are 100, yes, there is a general trend of increase with age, sort of not surprisingly, but it's super heterogeneous. Like it's extremely heterogeneous. And like even in people who are 20, like that's not even like, once you pass 60, like even in people 20, it's super heterogeneous. And so knowing where you are is really important, but more importantly, the optimal range doesn't go to 0. There is such a thing as too low a senescence. And I already alluded to the fact that P16 needs to be induced in macrophages to protect the tissue from immune damage. So sort of ability to make P16 in response to infection in macrophages is important. So some people have mutations or deletions in the P16 locus. So it's very common in cancer where it just gets deleted, and that kind of what makes benign cancer go or become cancer, right? But even sort of in the outside of cancer, there's some people have genetic predisposition. So they have these mutations, and the mutations in the locus, the sort of the molecular cause is you cannot make P16. P16 is a tumor suppressor. It's also the way the reason it's a tumor suppressor, it stops cell growth. So it can stop cell growth in a cancer tissue, but it also stops cell growth in a smooth muscle. So when in your blood vessel, it doesn't let the smooth muscle cells pile on and form plaques, essentially. So when you're missing that function, that growth arrest function, you are at the genetic risk for you can be at the genetic risk for cancer and heart disease, and specifically cancer would be colon, breast, and pancreas. So when your senescence is that low, you also have risks. So if your senescence is that low genetically, you definitely should not be taking a senolytic. or at least anything that has senolytic potential. Because we don't, so yes, genetic mutation is not the same as, my senescence being low for a year, but we don't know what cellular senescence is low for a year does. We know what genetic risk, what not having it for life does. We don't know. But if nothing else, there is evidence out there saying senescence is important. It has a protective function in the tissue. So taking something that can potentially ablate it across all tissues to nothing, really not a great idea.
Yeah, great point.
You know what I mean? So I think that it's I want people, and I'm all for experimenting, but I want people to be careful and understand that, low, as low as you go, decrease. That's not the right message for relief, right?
Well, and you're highlighting that you've seen it go up in some people taking this drug, which let's keep in mind when people are taking Fisetin, it's a massive dose, right? It's like grams per day of a highly concentrated compound. So it's doing all things that we don't understand, almost certainly, and perhaps it's causing some stress in other tissues. So I guess given what you're telling us, first of all, it doesn't work. It's not achieving the intended goal. Second, there are probably stressors we don't understand. So I think I would agree with your conclusion that in light of that data, there's probably not strong evidence to implement this right now, until something else comes along that tells us otherwise. But it sounds like, okay, so senescence is its own problem. Of course, the Sapere test that you've developed, which you set up very nicely for us, it doesn't just measure senescence. It measures several domains of aging biology that collectively can help someone understand their immune aging trajectory and their immune resilience. But it sounds like maybe you've seen some other interventions that you're pretty convinced by, right? That even if it's not necessarily the senescence domain that is benefiting, you see benefits on some of these other domains. So
yeah, go ahead. So as I mentioned, the other immune domains kind of go first. That's the decline starts to happen earlier in that. And that's one way to get senolytic effect. If you repair, because remember, immune system is senolytic, sort of good immune system is senolytic. And so if you repair those things, you can have a senolytic effect, but now you don't have to worry about, am I driving it too low? Is a senolytic bad? It's your own immune response. Your own immune system is not going to lead you astray. It's not going to drop it too low. It knows what's good enough, right? And so if you can restore the ability of the immune system to clear senescent cells, it's a much safer way of solving hardware senescence, right? That's sort of, and again, with a caveat, sometimes you can't. Sometimes your immune system looks perfectly fine and you're just accumulating senescent cells like crazy. We see that. And so, the solution there is to find the source and eliminate the source. But in vast majority of cases, certainly over age of 45, it's usually immune dysfunction that leads to accumulation of senescent cells. And sometimes it doesn't. But if accumulation of senescent cells usually kind of has the immune counterpart. And so I think that's, again, sort of important for people to appreciate that, it's a free senolytic. Just, take care of your immune system. It's a free senolytic in that sense. So let's introduce sort of, things we think about, because again, all the domains are connected because they're all part of adaptive immune system and they all talk to each other. These are I'm trying to think how to frame it. These are functions of the T cell biology that are really important. So I mentioned, T cells need to proliferate and then they need to memorize the response, and then you need to be able to respond. The memory cells need to re-engage when they see the threat. So these are all individual components of what T cell normally does, right? So they're not, they're also kind of different cells, but sort of that's kind of neither here nor there. So what we measure is ability of T cells to respond. So that's T cell proliferation, activation. So that seems to correlate really well with naive cell function. So again, not the count, but the ability of naive cells to function. And it also correlates with mitochondrial function. So mitochondrial function in T cells is essential because they're constantly using mitochondria to do things. So there is a really strong proliferation in their ability to respond and the need for mitogenesis. So those, even though that's not what we measure, but we don't measure conflict. Even though that's not what we measure, it's the sort of, there is a strong correlation there. And so things that are sort of changing your mitochondrial function will increase T cell proliferation kind of with that marker. So that's one thing. So the second thing, the counter to that, is T cell exhaustion. And so the word description comes from HIV patients where the immune system was exhausted. So it cannot respond to threats, and that basically what kind of causes the demise, right? And so there's a million markers of T cell exhaustion, almost literally. And so we picked a specific marker that seemed to have the strongest ability to predict the ability of immune system to be senolytic. So in general, all these domains were defined. Can they be senolytic? So if you change P16, what tracks with it essentially, right? So these are domains that are essential for the best in the class, if you wish. So among all the exhaustion markers, we picked LAG3, so not PD-1. We picked LAG3 as the marker of T cell exhaustion. So what LAG3 does is it mimics T cell receptor. So it actually competes with the receptor. So it's a brake on the proliferation. So if you have too much proliferation, lag kind of tempers that. But what that also means is that low level of LAG3 correlate with autoimmune disease because we want that break in proliferation. So again, lowering your T cell exhaustion to low, at least T cell exhaustion the way we define it, is not a good idea because that sort of comes at its own expense. So in the T cell exhaustion camp, that's where you have rapamycin and you have all the fluorescents, all these SGLT2 inhibitors. Those been shown to improve immune function through T cell exhaustion. That's their mechanism of immune function, published mechanism of immune function for rapamycin in humans, for SGLT2 in mice. And so if your T cell exhaustion is just at the low level of normal, you probably don't want to get on rapamycin because you can very easily give yourself autoimmune reaction. So it's, again, sort of know your audience, know your range, know where you are before you go on these things, right? So that's another thing we measure. So then the third thing is the balance, what I just described, the balance between proliferation and exhaustion. We take that into account because, again, kind of just to give you another piece of data, we have few people on GLP-1 that been tested before GLP-1 and now on, because now everybody's on it, but we don't have a baseline. So we have few people where it appeared. Seems to be more what that does, it restores the immune balance. So it brings down the exhaustion and it increases proliferation. So it actually doesn't just do one or the other, it actually restores it, which is kind of interesting because usually we see kind of treatment kind of do one or the other, right? So that's, kind of, I didn't know what to expect. I knew there would be some effect, but because, it's a pretty massively effective drug, so there had to be effect. But it's kind of interesting that that's what it does. But it has no effect on cellular senescence, for example. It's just rebalance, at least in a short term. It balances the immune system. So that the idea of the balance is really important. And that's where all the discussions of, do I want T cell proliferation, should I go on, urolithin A or whatnot, spermidine, what have you? Well, if your T cell exhaustion is really high, do you really want to bump that up first? Or do you want to address that? Like, that's where the balance is always considered in the clinical discussion is always considered. Like, where you are in both domains, you don't want to just do one or the other without considering the other. So that's that. So then the cellular senescence is sort of self-explanatory. And then the last thing we physically measure is the marker we call inflammation, but it's not the SASP, it's not the plasma cytokines, it's none of that. It's the receptor on the T cells that is present and then gets upregulated when T cells become terminally differentiated. What that means is your memory cells become bad, so they can no longer, they're still memory cells, so they still have the markers of memory cells, but they will not respond when the threat comes. So they become terminally differentiated. They have, they have ROS, they have weird mitochondrial function, they're just become bad cells. What that marker also does is, so T cells, the autophagy is really important for T cells because T cells are tiny with a huge nucleus, so there's very little cytoplasmic space. So being able to clear all the garbage out of the cell is extremely important because there is very little room. And so autophagy is not nutrient induced, it's always on essentially. So autophagy in T cells are really important. And so what that marker does, it interferes with autophagy as well. And what's been shown, for example, so most of the research for this, there's very little in longevity space on this, but most of the research comes from infectious disease space, where when you look at people with the same infection who recovered versus didn't recover, this marker always comes up as a non-response. So these are the people who have tuberculosis, sepsis, sort of all sorts of kind of infectious bacterial or viral diseases you can think of, just some malaria, just, basically anything that infectious people study. So that seems to be a marker of your immune system is really in trouble. And also in the P1P, in the mouse data that was published, that upregulation of that marker also blocks rapamycin from activating it up. So for example, your T cell defense is high, you're trying to, lower the rapamycin. Well, if this marker is high too, you're not really going to go there. It's sort of, so again, there are multiple, all these things exist in the sort of in the system. And so you kind of have to consider these things. On the flip side, what this marker does, it protects the tissue from immune autoreaction. So you need some level, because when your T cells kind of surveil and go around in tissue and, and macrophages and do things, this is the marker that tells them to step down in a sense. So you're not constantly attacking your tissue looking for things to kill. So again, low levels are not necessarily good. And so those are the things we measure. And there's thing that we calculate, and we call that immune longevity score. So it's the defense, the stemness, inflammation, and the balance. Those things are put together in a score that is built against the clinical definition of immune resilience that I'll address in a second. And that's the score. And the reason we came up with a score is because we used to have these conversations with clinicians. Well, defense is this, but the stemness is this, but they're not in balance. So you should do this. It's a really complex model to kind of crack them. And so we created the immune longevity score to be able to do that. But when we look at the model of immune longevity score, that's where we were like, oh, well, that's why it's really difficult, because, this thing is high good, but then it flips when you're 45, and these things interact. It's a really complex system. So that's why it was really hard to do it as a 1-by-1 marker. So that's what immune longevity score. So the clinical definition of immune resilience is people who are resilient to infections and suppressing chronic inflammation. If you got COVID, it was developed on the cohort of 50,000 people. Like there were 2 aging cohorts. I mean, every disease you can think of, renal transplant, all sorts of different kind of things that cause aging. So if you got COVID, for example, did you even notice you got COVID? Did you go to the hospital? If you went to the hospital, did you die? That kind of. So it's a clinical presentation of your immune system is failing. So it's not just, IL-6 or CRP or whatever. It's the actual physical presentation of how likely you are to, and that's what's called immune health grade. So immune resilience is grade 1. So the immune longevity score is predicting the odds of you having the best 100% or not resilience. So it's not full immune system. It's just are you resilient? Those are the things we measure. And so we present them as a hexagon again, so you can quickly look and kind of see. So it has to be filled in. If your immune system is perfect, it would be filled in. It has to be complete. And so when you look at it, you can quickly see where you are. And then it's a conversation of, okay, I'm short on this. How far out of the optimal range do I want to do something about it? If I want to do something about it, where should I go? Is it something I can change with a lifestyle, or do I need intervention? Which intervention? If I take this intervention, does it have known impacts on the other thing that is already optimal, and do I want to mess that up? That's where the real conversation, this is where real conversation starts. And I think it's really important. So for treatments in the kind of the list level, right? We've seen TPE have a really pronounced effect. So therapeutic plasma exchange has a really pronounced effect on inflammation and exhaustion. And we also had TPE. So TPE do nothing. As I mentioned, GLP-1s, I mentioned senescence. People who over-exercise will have really exhausted, we thought, the first time we saw that, we thought the client had cancer, had undergone chemotherapy. It was a massively high senescence. It was unfathomable to be that the lifestyle could be poor, that choice lifestyle was that damaging. So things like that you can have really profound effects of common things on that. So understanding, since COVID, there's a ton of viral reactivation. That T cell exhaustion would be really high there. There's not much you can do about viral reactivations. First of all, it matters because it's affecting your immune system. But then that means you really need to be tighter with your sleep and your diet, and you really need to try to dial a lot of things in because you're losing your ability to have a good immune system. Imperfect proliferation. On the inflammation marker front, gut health, I already mentioned, that's a massive one. Things it could be coming from excessive BMI, it could be liver, kidney health, it could be cardiovascular disease, it could be gut health. So anything where it's a tissue, the inflammation can be from a tissue, it's those kind of sources. So again, making sure that, you keep your BMI in check, dental health, gut health, it's an obvious thing that we all know we need to do. It's just, it tells me that you as a person can do it because of your immune. It just kind of focuses on things that really matter.
So you've given us a lot, a lot to digest, a lot of helpful interventions. So some watch outs, in the case of exercise, too much of a good thing can actually be detrimental, which I think we've seen in other domains of biology. And so, I guess for me, the takeaway is that a lot of people are doing things without actually knowing if it's the right thing for them, right? If like you've highlighted several examples of that for us. For example, if your T cell exhaustion levels are actually on the lower end of normal, or maybe even below the lower end, you could be doing some damage if you throw something like rapamycin at that, right? Whereas if you measure that and you actually see that it's high and there's a need for it, that can really be an effective intervention.
Exactly.
And I think that speaks to what we see in the clinic, right? We see some people that respond really well to certain interventions and others that don't, and others that seem to respond unfavorably. So I think what I've taken away from this is there's really a need to measure before we just throwing stuff at the wall and seeing what sticks. And now we have this tool with the Sapere test that actually allows us to do that, which I think is super cool. I really hope we see even greater adoption of this moving forward, because we can move from sort of average based medicine to a really personalized approach, which people like Grant are already using, and others. But so I think, if people take one thing away from this, I hope it's that you need to understand your immune system biology before you know what to do about it. Or if you need to do anything, maybe you're fine, right? We can't make guesses on this without testing. So if listeners want to know more about their immune biology and they want to see where they sit on each of these domains that you've walked us through, how do they access the test? What's their next step?
So the testing is available. So clients are quite sophisticated in this space. And so kind of I trust the people to know whether they need help or not. Working with physician is always what we recommend, because that sort of covers all your bases of trying to figure out what's next. But testing is available in some states, and we'll drop a link in the podcast notes. It's available in some states. In some states, it requires physician license. It's not available in New York. We don't have a license there. But again, make sure you are ready to measure. And I think the most, like whether you measure or not, right? The most important thing is remember your immune system matters, and things you do change that. So when you're reading articles about whatever therapy or whatever protocol, a bariatric chamber you just bought or whatever you consider, think about, ask the question, go to your favorite AI or however you do research and ask a question, what would that do to the immune system? Just know whether you care or not. Just have a sense, like, if there is a danger there.
I think that's a great thing to bring us home with.
Very good. Thank you so much for all this input. And I think it's just more in the direction of needing to measure before you just randomly guess that something's going to be good for everybody. Because on the clinical side of things, I could cause harm to people if I'm giving them medication where their immune system is in a certain state, and I could be doing significant good, but it's going to have to be measured rather than simply guessing on a population basis. So it's an interesting thing to contemplate and consider integrating into the practice.
Well, this has been wonderful. We'll put the links to the product and the key papers that we've discussed and any other key items in the show notes.
I mean, LinkedIn is where people can find me. I know I try to do my education there. I mean, it was really fun. It was really fun. Thank you for having me.
We'll look out for it, and we'll have to have you back once you have some more data on things like TRIM patients and all the other things you're measuring. We want to hear about it.
Yeah, sounds good.
Excellent. Well, thank you both.